Top Med Talk.
Hello and welcome to Top Med Talk. We are here in Australia for the PeriOperative Medicine Special Interest Group meeting in collaboration with Summit 3 and the PeriOperative Quality Initiative. Now, I'm Desiree Chappell. I'm your host here in Melbourne. It's been a wonderful meeting. Our whole team here we have Kate Leslie, Mike Grocott, and Monty Mythen with us today. I stole away just a little bit to do this next conversation. So it's just to be me and our very special guest. So today we have Ranjana Srivastava, who is from here in Melbourne. She is an oncologist and also an author and writer for The Guardian. So Ranjana, it's so wonderful to have you here with us today.
Thank you and good morning. My name is Ranjana Srivastava. I am an oncologist based in Melbourne. I am also a columnist for The Guardian newspaper, where I write on the intersection of medicine, ethics, and humanity.
Yeah, so you're here for the meeting today. You gave a plenary yesterday. It was wonderful. I think you had the whole room in the palm of your hand listening. Can you tell us a little bit more about yourself? You said you're an oncologist practicing here in Melbourne?
Yes, I've had an interesting career. I was born in Australia. I grew up in India. My father is an academic physicist. Then we moved to the United Kingdom, where I did some schooling, went back to India, and then we moved to the US. I finished high school in Minneapolis, followed by Pittsburgh, came to Australia to study medicine, subsequently got a Fulbright Scholarship to study an ethics fellowship at the University of Chicago, and lived in Chicago for some time, and then most recently went back to the US to do a master in public policy and public administration at the Harvard Kennedy School. I'm very fond of the United States. I have to tell you, my family lives there. Some of my closest friends live there. So that's my life. And now I'm based in Melbourne, and I have 3 kids and a dog.
Could sometimes more work than the 3 kids, but at least in our household. Fascinating. Tell us, you walked us through yesterday during your presentation, your plenary, about your love for writing and how you were able to create and infuse both of your passions into one. So tell us a little bit about that.
Sure. So, the plenary invitation came at the start of the year. These are very organized conveners. And I decided to talk. I'd been thinking a lot about this along the lines of shared decision making, but as you well know, the title of my talk had to do with arrogance and the quest for quality in medicine. And so the first part of my talk was around how paternalism in medicine should not necessarily be a forbidden word, and that patients expect us to guide them through decision making rather than providing them with a menu of options. And so I was making the point based on a very famous essay by a former editor of the New England Journal of Medicine that arrogance can be many things in medicine and not always bad, especially when it diminishes a patient's autonomy, but rather allows us to act in the best interest of the patient. But I didn't think I could speak all plenary about that issue. And I'm very conscious that whenever I speak, people are very interested in the dual life of a doctor-writer. As you alluded to, the other part of my talk was about what it's like being a writer. So I've always written since I was a child, and I know that many doctors are like that. They're good readers, they're good writers. And when I first entered medicine, people said, once you become a medical student, it'll be very hard to keep a journal. You'll be very busy. How will you find time to write? And I kept writing. And then when I became a doctor, especially an intern, people said, oh, definitely now there will be no time to write and to reflect. And paradoxically, I found that the need to write became more intense when I became an intern and a resident, because there are all these experiences you go through, and you're not going to sit down at the dinner table every night and say, guess what happened today and how sad I felt or how elevating this experience was. So I kept writing. I submitted things to various journals, wrote for JAMA for a while, I wrote for the New England Journal, essays in the perspective section, and then I used to write for an Australian masthead newspaper. The Guardian came to town in about 2013, and I pestered the editor-in-chief to let me write a column. At that time, and even to date, maybe there are, and I'm not aware, but I haven't seen a regular column about sort of medicine and humanity in any major publication for the public. And I just had this idea that people were interested in stories from healthcare because no matter who you are, you will have an encounter with medicine at some point, with doctors, with nurses, with healthcare. And I was fortunate that they took me on a trial basis for a while and never looked back. So for the last more than 10 years now, I've been writing a fortnightly column. That's every 2 weeks, write a column for The Guardian newspaper. The Guardian is not behind a paywall, which is something I really enjoy. And people can just Google the column and they can read it all over the world. I would never really have imagined having a public platform, which is both a place of great privilege and great responsibility. But I love it. And so that's what I talked about.
I loved it. It's so inspiring. I've watched people as they came up to you afterwards and talking about it. And I think at the end, you even said something like, if you're interested in writing and you've ever had an interest in this, the hardest step is just sit down and start.
One of my favorite things to do at the end of, I still handwrite a journal, although I write my books and my columns on a laptop so that just it's quicker.
Yeah.
But I still write on pen and paper. And one of my favorite things to do at the end of a journal is to, just before the anticipation or sourcing the next journal, like how the pages feel, how the lines look, what sort of cover it has. I started off with one of those little tween diaries with a lock and...
Yes, but I think it's great to inspire people. That sometimes it's a wonderful outlet, as you say, and especially in the world of medicine, in the field of medicine, there are a lot of things to work through. I think that, as you see in your daily practice, and I'm sure being an oncologist, really, that could be appropriate or something that you find cathartic for yourself.
Absolutely. And as I again said in my talk, I think the greatest beneficiary of my writing is me. It's lovely that people read me. I'm just finishing off a book for people who want to write, and it's basically how to write for the public. So how to write columns and essays and about the art and craft of writing. I'm hoping it will be published next year, sometime in the middle of the year.
Fantastic.
I'll keep you posted. And
Sure.
it comes from a place of coming to these conferences and coming to other places where people want to know about the nitty-gritty of writing.
Yes.
So many people are good writers. They're good readers. They want to write. And then it's other commitments and where do I find the time and how do I even start and what do I write about? As I'm giving a workshop today, and I teach a writing class at Harvard and also at the University of Chicago. So I've put all that information in a book for, the aspiring writer. And it's a short book on purpose.
Are they on Amazon, or where's the best place to find your books?
Yeah.
Yeah. We can put a link to all those on there. So if anyone's interested in reading more of your work, I think that'll be great, other than The Guardian, which we can hear from you every couple of weeks. So there were 3 major themes that you talked about yesterday, plenary. And the one I think you mentioned, arrogance. And it's that paternalistic way that I feel has become a bit of a dirty word in medicine, that we should have shared decision making. But why don't you expand on that for us, on that particular topic, just a little bit more? Because it wasn't until I really was listening to what you were saying that I understood your lens by which you look at through.
Sure. So for context, I run a geriatric oncology clinic. And as the name suggests, I see older people with cancer. One of the things that we often talk about is what matters to them.
Yeah.
And what matters to patients is different at different stages of life. And I think one of the trends, and several people were talking about this afterwards as well, is this trend in medicine to say you never need to say no to a patient. There's always something you can do and something you can give, but at what cost? I recounted in my plenary that there was a recent incident that sort of has stayed in my mind, where there was a patient who had a bowel obstruction in the context of a previous history of ovarian cancer. She had diffuse abdominal disease, and she came in and someone suggested that the bowel obstruction was technically fixable, and a couple of surgeons agreed to fix it. Another surgeon said, hang on, I think this will be a futile operation. I was called in to see the patient, and I said the median survival of such patients can range from a few weeks to a few short months. And I said to the patient that I felt also like the last surgeon did, that if she had the operation, she would likely stay in hospital. There would be a lot of complications from surgery, including pain, for instance, and she may not be able to get home. And we made a joint decision that it was not appropriate for her to have surgery, and she was vastly relieved. And the point I made in my talk was that so many teams had seen her. She had spent weeks in hospital, and everybody was inching towards surgery until one person said, "Hang on, is this appropriate?" And then another person said, "Actually, no, I don't think this is appropriate." And all of a sudden, we all pulled back. So I suppose in some way that is a demonstration of paternalism, because the patient was actually willing to go along with whatever decision the team made because she felt that we were acting in her best interest. So I think it's very important to think about what that means, not what we think it means, but actually ask the patient, interrogate their goals. But also, I think, and I was making this point, that as I grow older in medicine, I am much more prepared to say to both my colleagues and to my patients, I don't think you should be doing this, or I think you should do this.
Yes. Yeah. Just sometimes harder, especially with your colleagues.
Yes. And just to take back our listeners to the title of this essay, Arrogance, which was published in the New England Journal, I use the term because this editor, who wrote about his own experience of malignancy, so he was a famous gastroenterologist who unfortunately developed cancer of the esophagus. And he said clearly, as both the editor of the New England Journal, a doctor in the States, in Boston, he did not lack expertise. And he describes most eloquently in this essay how confusing it was and how overwhelming it was to receive advice from all quarters, intentioned about you should do this, you should do that. And the line that captured me is, he said, and then a wise friend pulled him aside and said, what you really need is a doctor who will tell you what to do. And he says, this is Franz Ingelfinger, the name of the author. He says, when I heard those words and when I followed that advice, a load was lifted off my shoulders.
A burden that all that pressure of like, I have to make the decision.
And there were really difficult decisions. Should you have chemotherapy? Should you have radiotherapy? And so yesterday after the plenary, it was very interesting to talk to a number of anesthetists who described these situations where people are sent to them in high-risk clinics, for example, or other places, and they're scratching their head going, really? Is someone going to operate on this patient? But it's almost a wave has been unleashed and everybody is just riding it. And then someone actually needs to stop and say, is this appropriate? Do you really want to have this? Is this in the best interest of the patient? And someone made a very interesting point that I completely agree with. It's so much harder to say no and to stop than it is to just keep going.
Yes. And I heard a conversation that you were having, we were all sitting around, and you were saying that whenever you first really started to be sharing your opinion, and that your surgical colleagues, when you first started talking to them, they're like, we don't want to send you our patients, that we don't want you to change their mind. Do you remember that conversation we were talking about?
Yeah, and it's so uncomfortable having those conversations with your colleagues, because who doesn't want to get along with the team and who doesn't want to be liked and respected and all of that? And here I was. It almost felt like I had planted some explosive in the midst of things that people thought were going fine. And then I would come along and say, actually, after assessing this geriatric patient with tools such as a comprehensive geriatric assessment, and we talked some of the fact that if you are operating on an 85-year-old, they are most likely dependent on an 85-year-old partner or spouse to look after them. And so what that loss of independence for one means to the unit. I remember distinctly having conversations in the emergency room with patients who the surgeon would say, we want to take you to theater, we want to do this or that. And the patient is, the most important thing for me is to live in my home and die in my home. I'm like, then that is not compatible with this kind of surgery. And so sometimes those can be confronting conversations for colleagues who are used to doing things a certain way. And I think for many doctors, the notion, and not just doctors, but especially doctors, I think the notion of not doing, not intervening is really difficult. One of the points that I try to belabor is no treatment doesn't mean neglect. Sometimes it's the best treatment. And that requires a frame shift. And it's taken years, but it's happening slowly, which is great to see.
Yeah, absolutely. We've had multiple conversations on Top Men Talk about shared decision making, and that point exactly. Like, just because you're not intervening and you've decided to stop treatment doesn't mean it's a failure, and it doesn't mean that you're failing that patient. In fact, you're giving them back something that could have potentially days life with at home with family. So, fair point. So we have a couple more minutes left, and I really wanted to talk to you about one of the other topics from your presentation yesterday, and it was about compassion and the compassion that doctors have for their patients. And this is a topic that you've written about in your column, and you shared a beautiful story with us and so inspiring at the end of your talk yesterday. So I just wondered if you would share that story with us again.
Yeah, thank you. It's a very moving story indeed. And I think I've made it a little bit of a theme of my talks to talk about the importance of compassion and empathy in medicine, because I still feel that it's regarded as an optional extra. And I don't think it should be. And if we think about our own healthcare experiences, who do we remember? What do we remember? We remember the people who were good to us. And of course, technical skill and expertise are really important. But I would say that most well-trained doctors have that. And so it's the other stuff that we remember. I think the value of compassion was brought home to me by an email that I received more than 10 years ago when I first started writing for The Guardian. And I tend to receive quite a lot of emails, and people leave the most wonderful and generous online comments. I know that some people are very wary of the online world, as we need to be, but I can honestly say that people are very good to me, and it's just been a wonderful source of human communion writing these columns. One day I opened my email and there was this letter which started fairly standard, and it said, I'm actually going to read it to you because I don't think I can do it justice by explaining. Dear Dr. Srivastava, I just wanted to send you a message to thank you for your columns in The Guardian. I'm a 31-year-old stage 4 cancer patient with liver and lung secondaries, highly chemo-responsive, but now my time is pretty limited. There is not a lot of writing on cancer that I respond to, or that I think really gives me a better perspective on the disease than I already have, but your writing always moves me and teaches me something different. I learn about medicine and the healthcare system and the act of living and the reality of dying. So then she says, I also really appreciate you talking about things from the doctor's side of things. I have a wonderful oncologist whom I adore, and in brackets she writes her name and she says, Australia is a big country, you never know who you might run into, and a liver surgeon who is dedicated and focused on trying to do the impossible and actually operate on my horrendously screwed up liver. You can always see this girl writing as she writes this, right? Very moving. And then this is the bit that really got under my skin. And I think this is the reason I talk about this patient and I read this out to an audience, because I think it's impossible not to feel moved by this. So here goes. It says, there's always a feeling as a patient that at the end of the day, the affection and the kindness your doctors show to you is just a thing that they put on to make you feel like they care. But you've taught me that doctors are just as human as they seem, which may be an obvious thing for you, but one that is easy to forget between the scans, the tests, and the constant navigation of your body as a complicated problem rather than as a human being.
Wow. That is for someone at the end of their life to have that view on the specialty of medicine and physicians as humans. Brings it home.
And also, I think so extraordinarily generous that at the end of life, she would sit down and write this email. It happened to be one of her last, because she died shortly after writing this email. I did manage to thank her. And this note, as I said in my talk, is more than 10 years old. And every year I take it out and I read it out to other doctors, and I remind myself about this is why the art of medicine will never go out of fashion. actually really does matter.
No, I don't think there's a whole lot more we can say about all that. I think that sums it up very beautifully. Ranjana, thank you so much for sitting down with us. I really appreciate you taking the time out of what I know is so busy for you just in life and here at the meeting. So it's been very special. And thank you for sharing that message with us, because I think that many of our listeners will really appreciate that and have something to consider. So thank you so much.
Thank you for having me.
And thank you for everything that you do in your specialty and your column. I hope you continue to do that for a while. And your books are coming out. You have a new one coming out next year that we will definitely catch up again with you on that and link to all the other books that you've written and share that with our listeners from all over the world, who I'm sure would love to hear more from you.
Thank you. I'm very touched.
Yeah, fantastic. All right. And thank you for listening to Top Med Talk. You can always find us at topmedtalk.com. It's the listen page. You can type in anyone's name, any specific meeting, and query all of our different podcasts there. You can find us on your favorite podcatcher. We're on social media. We're everywhere. If you find us on YouTube, give us a thumbs up, like us, subscribe to our channel. Every little bit helps. We also want to say thank you to our sponsors. Without you, we couldn't make talk free and open access to the world. So thanks everybody for listening. Cheers.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.